Good evening. Hi Ankita, good evening. Sundaramurthy, good evening. Harshini, hello, good evening. Vivek, hi. Vinitra, Lakshman, Rachit, Sikchi. Alright, so we are all set to begin. Okay, so welcome to lecture number 3 of our series. And today the topic is alcohol related disorders. Start making notes from here. Alcohol related disorders. What are we going to discuss in this? We are going to discuss in this subtypes of alcohol dependence, biomarkers for alcohol, alcohol intoxication, alcohol withdrawal. Good evening Kamal Bajaj, good evening Santarun Haq. Alcohol induced mental disorder, alcohol related amnestic syndrome, and last but not the least, good evening Shubham, treatment and rehabilitation. Now this chapter per se has less of theory questions and more of viva and practical based questions. For example, alcohol withdrawal may be asked as a case in your exam, and in that case your viva will be asked on treatment and rehabilitation. Okay, now these are only viva questions. This may be a theory question, Wernicke-Korsakoff syndrome and alcohol induced psychosis. You know, our teaching is exam oriented. So in our exam, this chapter has some viva questions, some case based, some theory question and some case based. I have planned this in lecture 3 and lecture 4. Today and next week we are going to discuss alcohol only. This is the most important chapter in de-addiction. A psychiatrist is supposed to know everything about alcohol de-addiction. For that you need not do a DM de-addiction. So practical points, you need not refer this case of alcohol dependence to a rehab center or de-addiction center. Even if you are an independent practicing psychiatrist, you should know how to manage it. You know, one of the student has messaged me in private practice, how do you do de-addiction? Look, the idea is some of you have just completed MD and might be starting practice. Some of you are preparing for DM and de-addiction. Some of you are still resident first year, second year, third year. Look, in institution, the way we practice de-addiction and the way we practice de-addiction in a private practice is a little different. In institution, our job is detox, mainly detox. Detox is treatment of withdrawal. After withdrawal phase is over, we discharge the patient, and then de-addiction is maintained on follow-ups. and it is possible that the patient discharged by you is followed up by your colleague, your senior, your junior. The difference being in private practice is you discharge the patient, you keep the follow-up. Although this is a very simple difference, but practically it is a huge impact. Suppose you spent your minutes, hours counseling the patient, de-addicting the patient, and the patient relapses. The family members are not satisfied with you. You are not satisfied with yourself that my patient relapsed. The patient is not satisfied with you. Are you understanding? So along with the theory and the practical exam, I would like to touch a few topics, a few concerns in private practice, if you are comfortable. Shall we talk about few basic tips and tricks of alcohol de-addiction in private practice, the points to keep in mind, what to say to the patient, what not to say to the patient, what to say to the family members, what not to say to the family member, what to avoid, what not to avoid, what to give, what is available. Like I always say that our Kaplan Sadok promotes methadone too much for opioid, but is it available freely? I don't think so. You know, even in Delhi, to get clonidine also is not that easy for alcohol. To get tramadol also is not that easy. So, you know, sometime I say that book mentions dash as drug of choice, but the practitioner has to see the availability, has to see the affordability, has to see a lot of factors before deciding the drug to be administered. Are you understanding me? So what I planned is, today I intend to cover up to this if I can, and in the next week I intend to cover this, because treatment and rehabilitation I have to discuss in depth. Are we all set? Shall we start? You know, I'm not going into epidemiology of alcohol use, so many people drink, what is a standard drink. We are not here to discuss what is the difference between wine, whiskey, your beer. You know, I don't want to waste my time and expertise on discussing about etiology of alcohol dependence. These things are not asked. I will straightforward move to the point, to the topic, subtypes of alcohol dependence. Many examiners would like to ask you, what is the difference between type A alcohol dependence and type B alcohol dependence? Type A alcohol dependence is late onset. Type B alcohol dependence is early onset. Type A alcohol dependence has few childhood risk factors. Type B alcohol dependence has many childhood risk factors. This has few of alcohol related problems. And little psychopathology. This is more of a severe dependence. There is a strong family history of dependence associated. There is much of comorbid psychopathology. These patients have comorbid stress factors also present. They respond to training in coping skills, and they respond to interactional psychotherapies. This is as given in Kaplan. Examiner sometimes would like to ask you what is the difference between type A dependence and type B dependence. You would say sir, type A is usually late onset, type B is early onset, type B is less risk factor, type B is more risk factor. Number 2, 3. Type A has little psychopathology, type B has more psychopathology, type A less likely to be family history, type B more likely to family history, type A mild dependence, type B severe dependence. Since the stress factor is present, these people need training in the coping skill, and those people respond to interactional psychotherapies. Type A and type B alcohol dependence are given in Kaplan.